How many of you refer your patients for crown lengthening? And how many of you watching this video do not know anything about crown lengthening and would want to know more? If you are one of those who refer your patients and would try to do yourself but do not know where to start, this video is for you. I will be discussing some procedure tips in this video. And if you do not know if you should refer your patients for crown lengthening, that is, if you do not know what are the indications for saving the tooth or restoring it, then this video is again for you. I will be talking about indications of crown lengthening and the contraindications, and will give you some tips about the procedure. For those of you who don't know me, I'm Dr. Swati Gupta. I'm an international trained periodontist and I'm a DMD in the US. I'm the author of the book Quick Review in Clinical Periodontics, which is a handbook for periodontal procedures and periodontal basic knowledge. And if you like this video, please don't hesitate to like, share and subscribe. For any of the questions, write your questions in the comment section or email me for any kind of coaching queries. Without further ado, I'm going to start with crown lengthening. So what exactly is crown lengthening? Now, crown lengthening is a procedure that aims to increase the clinical crown length of a tooth or teeth for either aesthetic or restorative purposes or a combination of both. Having said that, what are the indications for crown lengthening? Indications could be when you have some gingival caries or decay or a fracture and you want to know the extent of that caries, if that teeth can be restored, how deep is the fracture. Usually you would know if you can save in a case of a fracture, but sometimes to see a fracture line that you think is not going really deep and the tooth can be saved, that could be a good indication for crown lengthening. When you have inadequate crown length for retention, that's again a very good indication for saving the tooth, because you are trying to give a crown, you think that the tooth can be saved. Now this is a very important point I'm going to be discussing is the crown root ratio. And third point is unesthetic gingival heights, that is an indication for aesthetic crown lengthening. You have patients who probably underwent orthodontic therapy or who generally have unequal zenith lines, an aesthetic look, and these patients you can easily do aesthetic crown lengthening. Now, how would you do it is again a topic for another day. It can be laser, it can be surgically with a scalpel, but again we'll not get into that in this video. Contraindications. For any procedure, a case selection is not only dictated by your indications, but you should also be clear on contraindications, because you have to tell your patients about it. You have to tell them if the procedure that you're going to do has a good prognosis or no. So the contraindications: surgery would create an unesthetic outcome. It often happens that you would undertake the procedure, you would do the procedure, but if that procedure can cause recession, if that procedure can cause black triangles in the aesthetic region, if that procedure can in the posterior region cause again like recession of that area, you would not want to do crown lengthening. Something like if you think that the patient has a thin biotype and you are doing the procedure and that can lead to the crown margin, you create everything perfectly, but over a period of time, because of whatever reason, there can be an unesthetic result or a result that is not going to be favorable, you will never do a crown lengthening there. Deep caries or fracture that would require excessive bone removal on the contiguous teeth, that's again a very good contraindication. And the tooth is a poor restorative risk. Like again, I've been saying all this while, case selection is very important, specifically when you are trying to save a tooth. When you're trying to save a tooth, you have to look at very important feature, and that is crown root ratio. Just going to give you an example. So look at this case of mine. I did the crown lengthening, but when I was thinking about doing the crown lengthening, the questions were, first when this patient came to me, the question was, do I extract it or do I save it? And what helped me decide if I should extract or save was the crown root ratio. Now, what is crown root ratio? I'm not sure if you know that Schillenberg, the book of fixed prosthodontics, has been written by him. Now, they talk about in terms of fixed partial dentures or abutments, but the same principle applies when you're talking about saving a tooth or about restoring a tooth. The crown root ratio, ideally, which is 1:1.5 and minimum of 1:1. That means when you're trying to expose the crown, you have to think about how much of the root will be there and how much of the crown will you be exposing, which brings us to this picture, which is your anatomic crown length. Then you have anatomic root length, and if you are going to do the crown lengthening procedure, we are to consider two main factors, which I will be discussing, is biologic width, the ferrule height, right? And after that, what you'll get is effective crown length. Let me point here. So after you've done the crown lengthening, if you've shifted the bone margin, and or if not even if shifted the bone margin, but you've increased your effective crown length, then the factors that you have to consider is biologic width, ferrule height, and the effective crown root ratio. How much of this and how much of the root is there with you, and that should be minimum at least 1:1 should be there for you to consider this procedure. So let's go back to this picture, and if we can see in this picture, so this is not my case, this is a random picture I got, but if you see this case, in this case there is this there is a post there. Probably it looks like the crown, the core build-up material is gone, the crown is gone. Now in this case, there are two options that you can have. Either you can build it up with again put some more core material and put a crown alongside, but definitely you can see, let me again have my pointer here, we can see that the margin of your tooth, that is remaining tooth structure, is literally at the level of the gingiva, and some level it is also sub-G. That means you would need to expose the crown so that what we talked about, one is the ferrule height should be there, second, which I'm going to be talking about, is biologic width, and third is adequate width of attached gingiva. Again, I'll be talking about that, but the first call that you have to make in this case, if such a case comes to you, is if you expose the crown, just if you try to save it, if you expose it, how much of the crown root ratio will be there, right? So same principle. If right now, let's imagine if this is 4 and this is probably 11, just a number, I don't really know how much is it, but I'm just making a number, your ratio is not that great, but if we were to expose a little bit, if we were to actually, you know, bring your margin, let's do on this side, or wait, if I was to expose it, and if I was to bring the bone margin here, right, to do osteoplasty, bring the bone margin here, and then we have to see what is our crown root ratio. And if your crown root ratio is in the number of 1:2, that is obviously ideal. 1:1.5 or 1:1, that is, again, that would be great. So you always have to understand in terms of like 4:11, so that is easily a good number, right? That is a good number. But if you were to expose it and this becomes probably 6 and this becomes 9, then again you'll have to do your calculation, see how much of a crown root ratio will be there, and that will help you understand if that is an ideal case that you're looking at. Now once you've decided that, okay, fine, my crown root ratio seems to be okay, what are the other two factors? One is the ferrule margin that we talked about, which should be at least 1.5 of the ferrule margin. Let's go to biologic width. Now biological width is something that usually everyone struggles to understand, but also I'm going to talk about a little bit on attached gingiva. So if you see in this picture, I hope you understand what is free gingival margin, what is attached gingiva, how to calculate the width of attached gingiva. My handbook on review in clinical periodontics. It gives you a brief idea of everything. There are lots of clinical pictures. So if you're the kind of person who doesn't want to read a lot but just like get a brief idea, definitely this book is for you. And the link for the video for my book is in the description. Let's go to biologic width. Now, biologic width is the definition. The definition is physiologic dimensions of junctional epithelium and connective tissue attachment. Perfect. This picture, I'm pretty sure you know, most of my pictures are from Karen's and Linde. This is another picture. So picture wise, if you see, this is your bone, right? And then we say connective tissue, junctional epithelium, and this is your gingival sulcus. So this whole dimension that you see above the bone is referred to as biologic width. So we say that when you are planning a crown or any restorative margin, this particular dimension should not be violated. As in, this dimension, which is almost 2, and then we say 3 millimeter, anything should end up above this. Okay, nothing should encroach this area, because if you do, then you will have consequences. Let's try to understanding with this x-ray. That would mean if I was to do a crown, if my crown margin ends somewhere here is my bone margin, that means I violated the space, because think clinically, this area is somehow, this area is probably occupied by the gingival margin. That means your gingival tissues, your connective tissues getting inserted in that area. And if you were to put your crown, impinge, when you're thinking about going sub-G, if you were to put your margin of the crown or a restorative margin close to that bone, that means you've totally impinged into your connective tissue area, and that's what we call as biologic width violation. I understand it's a very difficult concept to understand, but I hope I've helped you understand a little bit about biologic width. And what happens if you actually put your restorative margin in this biologic width, in this zone, you will have inflammation, pocket formation, bone loss, basically, because you are, all these things are the consequences when you violate the biologic width, right? And how do you know it? So I'm not sure if you notice, but notice in patients who have a very good hygiene, and you probe around the crown. If it hurts, the moment you probe and the patient jumps with pain around when you're probing around the crown, and then try to look in the x-ray, how far is the crown margin from the bone. If that is happening and the crown margin is close to the bone, you can very easily make out it's a violation of the biologic width. Not necessary every time you probe around the crown it's because of violation and there is a bleeding, there's a violation of biologic width. It could be because there is plaque, the patient is not flossing. But to come to a conclusion, you have to look at the x-ray also, because it's not really easy to just clinically understand there's a violation happening because there's erythema and everything. And that's why we say that at least 3 millimeter should exist between your gingival margin or your free restorative margin and the bone crest. Okay. Now let's talk about, again, this is from Karenza. Let's talk about when do you do crown lengthening. Now you've established that my crown root ratio is fine. I can proceed with saving the tooth. Once we've decided about saving the tooth, we looked at biologic width and we looked at your attached gingiva, and we'll be coming to taking those factors into consideration. But one thing to consider is, now, am I doing crown lengthening or am I doing crown lengthening by gingivectomy? I just wanted to bring up this point here because gingivectomy is not very different from general crown lengthening. They're the same procedures. The only difference is in gingivectomy, you do not do osseous contouring. So let's look at the example here. Now, with less than 3 millimeter of soft tissue between the bone and the gingival margin, or less than adequate attached gingiva, a flap procedure and osseous contouring. We just talked about that ideally the space that is between your free restorative margin and your bone should be almost 2 millimeters, but we prefer that at least 3 millimeters of the space should be there. You're considering gingival sulcus into that consideration. So if the space is less than 3 millimeter, we say the less than 3 millimeter of space exists between your gingival margin and the bone crest, we will definitely need osseous contouring. That means we need to cut this bone a bit right? Osseous contouring and create the space of 3 millimeter. However, if you have greater than 3 millimeter, now what are the scenarios when you will have a greater than 3 millimeter soft tissue? Something like patient is getting orthodontic treatment, or because of inflammation, a lot of pseudo pockets are there. Those are the areas, those are the time when you will have greater than 3 millimeter of soft tissue. Now there, if you have to maintain an adequate relationship, we do not need to cut the bone. All we need to do is just cut the soft tissue a bit. That means we only cut this much of the soft tissue and we were able to get our 3 millimeter. So the difference between definitive crown lengthening and between your gingivectomy is that in gingivectomy you do not do any osseous contouring. Talking about the decision tree. Now, decision tree considering adequate width of attached gingiva and your distance between free restorative margin or CEJ till your bone. One scenario is you have adequate width of attached gingiva, that is type 1. One scenario is minimal attached gingiva or keratinized gingiva less than 2 millimeters. Now, if you have adequate keratinized gingiva that is more than 2 millimeters, we consider as type 1, you have subgroup A and B. In subgroup A, your distance from the free restorative margin to the bone is more than 2 millimeters. The same scenario that we discussed. Obviously, if the distance, if the adequate amount of soft tissue is present, you would go with gingivectomy. However, if that distance is less, like we discussed before, you would go with osseous contouring, just like in this scenario. So this was basically, if we were to consider, this would be your type 1 subgroup A, type 1 subgroup B. Let's go to type 2. Again, in type 2, your keratinized gingiva itself is less. That means you would need to increase the width of attached gingiva as well as here, but your distance is more than 2 millimeters. So that way, our bone distance is fine. We just need the width of attached gingiva more and the keratinized gingiva more. So you would do something called as apically positioned flap. However, if your attached gingiva or keratinized gingiva is also less and the distance between the bone is also less, you would do APF, apically positioned flap, with osseous contouring. Now, as a general dentist, I do understand that you are not trained to do any apically positioned flaps or even osseous surgeries, but definitely if you were to refer a patient and if you were to understand how to at least do a basic crown lengthening or a gingivectomy, this would be a good decision tree for you. So my tip is that first have a good case selection, and case selection, look at the crown root ratio, look at your biologic width, try to understand what is attached gingiva, what is present, and then make your call. If it's a simple crown lengthening or if it's a simple gingivectomy, you can definitely do some courses and try to perform these procedures on your own. However, if you think that yes, this procedure would require like we said, APF or osseous contouring, and you are not trained to do that, at least you can tell your patient about it, train them, at least tell them what exactly to expect before you send them to a periodontist. So I hope this decision tree makes some sense to you. Now let's talk about crown lengthenings. So we were talking about a surgical and aesthetic crown lengthening. Again, the difference between surgical and aesthetic crown lengthening is not a lot. We will be seeing the difference only in terms of why are you doing that particular crown lengthening. So surgical or functional crown lengthening is mostly your restorative reasons that you do it, and aesthetic is again for aesthetics, as the name says. So surgical crown lengthening, generally crown lengthening, is accomplished by soft tissue excision, just like we talked about, by flap, with or without osseous. And this is your armamentarium other than your scalpel. 50 number blade is your end cutting carbide burr. I got this picture from internet, but it is a very good picture because it tells you the kind of burrs that you would need. So the end cutting carbide burr to lower the marginal bone levels, a flame shaped carbide burr if you have soft tissue and granulation tissue, and a round carbide burr, it could be number 2 or number 4 depending upon which location you are in, to harmonize the marginal bone. You can also find this again in a book, but these are the most commonly used burrs and these are really good. So let's go to now once we've discussed the blade and everything, I'll show you through my pictures how exactly I proceeded. So this is the case that we were talking about before. So once I established there is good adequate amount of keratinized gingiva, the crown root ratio is going to be fine, I proceeded with my procedure. So what do you do in surgical crown lengthening? You make incisions. So if you can see my blade, I'm right now making incisions on the buccal and the palatal or the lingual aspects. Now remember that you do not always have to make an incision on the palatal aspect also if it's not needed. So in this case it was needed, so we'll make incision because we are doing a crown lengthening throughout. So you make an incision on the palatal as well as your lingual. So these are basically marginal incision or scalloped incisions that you make. And after that, so again another picture, you can see how I made the incisions of the palatal and the lingual. And then this is with my Kirkland knife, a gingivectomy knife. I'm just removing the soft tissue here. Now, if the excision of your soft tissue would at least leave 3 millimeters of keratinized tissue, then like we discussed, there's no need for osseous surgery. So in my case, I don't have the extra for this picture, but in my case, there was good amount of distance between my restorative margin and the bone, the planned distance. And that's why I just proceeded to cutting the soft tissue and there was no need of a osseous surgery. However, if there was going to be less than 3 millimeter, then yes, definitely, like we discussed, we would have gone with APF or osseous contouring, whichever would have been necessary. And this was my outcome. So you can see this is literally post-op immediately after the procedure, but you can see how much of the clinical length I gained by doing that procedure. My second case, again, this was again, if you can see, it was done from tooth number 6 till tooth number 11, 6 to 11. The reason we were doing is you can make out the patient has a lot of subgingival decay and caries. So the purpose was to expose the crown. So you can see we are measuring the clinical crown length. We are seeing how much we can be achieved more as compared to the teeth that are lesser in clinical height. And then again, crown root ratio that we discussed. Again, this is the same picture of doing the probings and to check the crown length. Again, with my 50 number blade, I made the surgical excision, the scalloped incisions, and with my Kirkland knife, I'm just removing all the tissue. Again, in this case, I did not have to do the osseous contouring because I had a lot of distance between the bone and the soft tissue, between the margin. And also the reason was here just to expose the decay area. So you can see under that whole clinical crown, you can see how much of the area that got exposed and how much of a decay was there. Now coming to aesthetic crown lengthening. So aesthetic crown lengthening, what do you do? Like we were discussing, the difference between functional and aesthetic is obviously because of the reason you do it. And the another thing is that in aesthetic crown lengthening, we usually only raise a facial flap because it is for aesthetics. You do not want to touch your interdental papilla at the risk of causing recession. You can do gross osteoplasty if you feel that it's very bulky and there is bulky bone or the contour is really bulky, so you can definitely do osteoplasty, and if you want to alter the crustal levels also in aesthetic crown lengthening. Height of the interdental crust we do not reduce. Again, interdental crust determines the whole let me have my pen here. So your interdental crest, like if this is the thing, your interdental crest, this papillary region, we don't want to touch it because this will cause black triangles. So when you are going to do your incision lines, you're very clear on how you do the incision lines and how you do the osteoplasty without causing any damage to your interdental papilla. Crown lengthening for aesthetics aims to correct either a gummy smile or a gingival overgrowth, and I think we pretty much know that. Now let's go to again my pictures. So this is again in this patient. If you can see, the patient was not really happy with this, with the difference between how both the anterior teeth are looking, the gingival margins. So again, I just and also if you see the difference here between her lateral incisors, they were also uneven margins. So I proceeded from here, then you stop here, you make an incision here. So again, if you see, we try not to really touch your interdental papillary region, and how we do it, right? And this is again not a very clear picture, but you get the idea. And this was the post-op. So most of the difference, if you can see, like how you see the zenith lines, they're at the same level now. And if you see in the lateral incisors, they got the same shape as compared to what it was before. So this was the aesthetic crown lengthening. I hope with this video I've been able to make you understand what is crown lengthening, what is the case indication for choosing to save a tooth or extract a tooth. And if you, like I said initially in my video, if you are trying to do crown lengthening, I hope you've gotten a little bit of an idea how to proceed with it, and then you can probably take some courses and go ahead with doing that in your practice. If you have any questions, again, put that in the comment section. If you like the video, like, share, and subscribe. And for any coaching inquiries, email at the email in my description. I'll see you in the next video.